So narcolepsy has been described, as you know, a long time ago clinically by Westphal in Berlin. In familial cases, the kids and the mother has been affected with sleep attacks and cataplexy. And just a few years after, Jean-Baptiste Gélineau from south of France, and more and more, and after Daniels in 1937 has been described the tetrad of the full symptoms of patient with narcolepsy. So excessive daytime sleepiness, not just sleep attacks, but short naps with dream contents with refreshing value. The cataplexy, as you can see here, is a loss of muscle tone on the face, mostly for partial cataplexy, as you can see here, clearly described. And in this young boy is more generalized cataplexy, he may fall down. So there is several pictures, several phenotypes of what is cataplexy. There is hypnagogic hallucination, or also hypnopompic hallucination, where you wake up at the end of the night, often associated with sleep paralysis and disturbed nighttime sleep. So this is the tetrad, the pentad, and more other symptoms has been described in patients with narcolepsy: abnormal dreams, REM sleep behavior disorder, somnambulism, obesity, precocious puberty. So it's not just EDS and cataplexy, and we cannot forget that when you want to improve quality of life of the patient. The age at onset, as you know, is very often in the adolescent age, mostly as 15 years old, with a little second peak around 35. It's underdiagnosed condition, is an orphan disease, and recently, based on European Narcolepsy Network, we did publish that still 8 or 10 years to be diagnosed, unfortunately. So we did publish recently that the first scale to quantify the narcolepsy symptoms, and not just excessive daytime sleepiness and cataplexy, but other symptoms that really are key for a patient in terms of quality of life. The REM sleep has been described as sleep onset by George Vogel in US, in Atlanta, in the 60s, studying dreams in patients with narcolepsy. It reported that there is a sleep onset REM, so during the night, and that has been confirmed in Chicago by Rechafin and in Montpellier by Passon a few years after. And as you can see here on the top, an adult typical patient with narcolepsy will fall asleep in REM even during the daytime, and especially during night times. And this is just 50% of cases. You cannot be sure if there is no SOREM that patient can be affected with narcolepsy. In addition to this nocturnal SOREM, there is also other problem during the night in patients with narcolepsy, and especially during the REM sleep, with a loss of muscle tone, as you can see on the anterior tibialis, on the up figure, and on the bottom figure is on the chin, with phasic and tonic activity. And my friend Alex Irando will discuss that a lot. But in patients with narcolepsy is highly typical, even if sometimes the behavior is minor or even nothing, is just seen on the trace on the EMG activity. We did report as well some periodic leg movement in NREM in the wake time, higher than compared to the control, and especially with the age effect, but is often higher in patients with narcolepsy. But what is more specific is periodic leg movement in REM sleep compared to the controls. And as you know, this main discovery is the SOREM, the sleep onset REM period during the MSLT, has been reported by Mary Cascade. And here, as you can see, is SOREM on the 4 first snaps, and for the last snaps is on NREM in contrast to REM. And there is a direct entry from wake to REM in these cases. And again, REM sleep latency is more than short, because it's almost zero if fall asleep directly in REM. So this is a major discovery. First is the clinical signs. Second is is REM sleep phenomena, and third is the discovery of narcoleptic dogs by Knetch and Bill Demand in the 70s, and with huge work by Emmanuel Mignot, he discovered that there is a mutation in the receptor 2 of the orexin, also named or hypocretin genes. That's correct for Labrador and Doberman. And in the 80s, the discovery of HLA-DR2 at the beginning and more recently with DQB10602, because this is for all of ethnic origin that compared to DR2, which some differences between ethnic origin. And this association with HLA DQB10602 is huge. The odds ratio is more than 250 that compared to other known disorders associated with HLA. It's really a huge association that leads to autoimmune diseases. And based on this discovery, the first criteria to diagnose narcolepsy in the first international classification of sleep disorder in 1997 had as a clinical symptom excessive daytime sleepiness. Often cataplexy is not mandatory to be in, and associated with other symptoms, sleep paralysis, hypnagogic hallucination, automatism, and disturbed nighttime sleep. That disappear in, we will see that in a minute, but in the more recent classification. And just one of the following among two parameters from the PhD, sleep latency below 10 minutes and REM sleep latency below 20, contrast to 15, as you know, currently accepted, and the MSLT is at least 2 SORM or MSLT below 5 compared to the 8 minutes currently accepted. And HLA-DR2 was in at that time. And the last major discovery for narcolepsy was the orexin peptide has been found and described by Sakurai, Yanagisawa, Tom Kilduff, Delicia in lateral hypothalamus, and the discovery of the loss of orexin in narcolepsy type 1 is done by Emmanuel Mignot and Jerry Siegel in the brain of patients with narcolepsy, as you can see here, with a loss of more than 80% of neurons. And they did report it as well that is completely absent when you measure orexin in the CSF of patients with narcolepsy. This has been described in 2000, and we did this Lancet review with Emmanuel Mignot in 2007. And you can see here a patient with narcolepsy with typical cataplexy have mostly in red low orexin level between 110 compared to the control in black. But you can see patient with narcolepsy without cataplexy with abnormal orexin level and patient with atypical cataplexy. I didn't discuss that, but some patient may have in between narcolepsy, cataplexy with atypical, rare, unilateral, and so on. And this discovery of orexin loss reinforced the autoimmune hypothesis with some discovery of CD4 and CD8 T cell in the blood that will cross the blood-brain barrier and will recognize some epitope within orexin neuron and destroy the orexin neurons. We proposed this review recently that make a comprehensive review of where we are so far in this autoimmune hypothesis. And orexin discovery as well is key to understand most of the symptoms of patients with narcolepsy. And this Nature paper of Cliff Saper report that, as you're aware of, orexin is key to promote wakefulness, activated the ALC, the TMN, and the RAFA, and so the wake monoaminergic neurons. And when you have no more orexin in patient with narcolepsy, you will be in trouble with a mix up of different sleep stages, and that may explain part of the symptoms. This nice figure, a little bit complex but highly comprehensive, proposed by Tom Scammell, report that there is huge interaction with several brain regions implicated in wake and in REM sleep. And orexin neurons will activate receptor 1 or receptor 2 orexin genes. And if you activate orexin receptor 2, especially in the TMN, histaminergic neurons, you will increase wake. If you modulate the VILPAG and the pedunculopontin in the brainstem, you will decrease the REM. And if you activate just the ALC, you will, with the orexin 1 receptor, you will increase wake and decrease REM sleep. So the involvement of orexin is key to understand the wake promoting effect and the suppression of the REM sleep. And based on all of this discovery, a lot of mice model of narcolepsy has been developed: orexin knockout mice, orexin receptor 1 knockout mice, receptor 2 knockout mice, and the more exciting was orexin ataxin 3 mice with very close and mimics of patients with narcolepsy. And as you can see here, there's a lot of direct entry in REM sleep during the light phase, the dark phase, that is almost the same as SOREM in humans. But in mice, it's impossible to separate the direct entry in REM directly, not the 15 minutes, but direct from wake to REM. But they cannot separate that to cataplexy and sleep paralysis in mice. That contrast with what we do see in humans, because the patient during cataplexy are completely awake, and in REM sleep they are for sure in sleep. So it's a classical way to focus on cataplexy in mice, but I think it's a little bit different as well. So based on all of this distribution of orexin and orexin receptor 1 and 2 and the absence of orexin in patients with narcolepsy, that may explain most of the symptoms: frequent vivid dreams, nocturnal sleep duration, sleep hallucinations, nightmares, REM sleep behavior disorder, sleep paralysis, cataplexy, muscle atonia, and we did not discuss that, but there is also some autonomic dysfunction in patients with narcolepsy. So the recent classification just came out a few months ago in June this year, changed a little bit the criteria for narcolepsy type 1. So there is no more the criteria of 3 months compared to the ICSD-3. And the item B is different as well. You should have cataplexy and either MSLT below 8 minutes and at least 2 SOREM, or a SOREM within 15 minutes of the PhD. So it's no more a SOREM on the PhD that replaces 1 SOREM on the MSLT. It's alone plus cataplexy and have to be diagnosed patient with narcolepsy type 1. And for sure, orexin deficiency, because type 1 is orexin deficiency. But it can be without cataplexy in cases of orexin deficiency. But nobody do that in routine, unfortunately, except in few labs, including my labs and the one of Giuseppe Platti in Italy. For narcolepsy type 2, there is no change, 0 change in the last classification. So MSLT below 8 minutes and at least 2 SOREM, and the SOREM at night may replace 1 SOREM during the MSLT, and orexin need to be above 110. And for IH, idiopathic hypersomnia is not my topic today, but there is just one minor change: is PhD and MSLT cannot be consistent with the diagnosis of NT1 or AT2. But recently we did publish a nice paper, and the same has been reported by my friend Gert Can-Lammers, that patients with intermediate orexin between 110 and 150 with typical cataplexy exist. It's rare, but that exists. So there are patients with cataplexy and in between orexin levels, so they cannot be diagnosed NT1, they cannot be diagnosed NT2. So the classification is not enough for these rare cases, but these cases exist. And you're probably aware of that patients with narcolepsy, especially those with normal orexin level, may change time to time. They may involve some NT2 to NT1, NT2 to IH to NT2, and even to normal condition. Sometimes it's just a transient problem. So based on all of that, the SORM on MSLT cannot be the gold standard because of the change time to time. There's 3 seminar papers, the first one by Lynn Trotti and David Rye in Atlanta, showing that when you do test and retest of MSLT in drug-free condition, there is a huge change, as you know, and the criteria is no more good with 50, so half of cases have no more the criteria when you redo the test. And this has been done in my lab as well and in Stanford lab, and there is unreliable MSLT. And if I just report what we did see in my lab, in patients with NT1, just 81% of them have similar criteria when you do and redo the same MSLT. And if we focus on NT2, it's 47 of them. And for IH, it's 25% of them. So it's not reproducible. And this is a big problem because NT2 is a disorder defined by MSLT. If you have no MSLT, there is no NT2. So if the diagnosis, the criteria is not robust enough, is very problematic to perform a diagnosis based on that. We did propose as well that in NT1, there is with age progressive decrease in SORM, increase in sleep latency, so we need to take into account this age effect. Look at 2 MSLT. The first is 2 SORM, the second is 5 SORM. And for the first, in the up of the figure, there is NREM before REM, contrast to the figure below. So there is a lot of parameters that you can see in MSLT and not just the mean sleep latency and number of SORM. You can see like the REM sleep duration. So a lot of things that may be shown. And we did propose that sleep recently that the best parameter to separate patient with orexin deficient versus patient without orexin deficient is mean REM sleep duration. I have no time to go into the details, but it's well done. All patients had orexin measurement in drug-free condition, or most formed subject. So probably the best parameters is REM sleep duration in our hands, and better to diagnose patient with narcolepsy than the classical 2 SORM and 8 minutes for the mean sleep latency. So there is a huge overlap between NT1, NT2, and IH, especially if you did not measure the orexin, because that is the criteria to diagnose NT1 for orexin deficiency, but nobody do that in routine. So we propose in sleep medicine review how to best separate, but also to have in mind that there is a big overlap in between. Just one point on medication. The most medication that are active in cataplexy are also active in decreasing REM sleep, and direct entry in REM sleep has been seen with pitolisant here in mice. There is a decrease in DREM and REM sleep percentage. And also antidepressant has been reported by the previous speaker, but is not published in the patient with narcolepsy because they are off-label drugs. And oxybate is probably the most exciting drugs to decrease REM sleep and the number of shift stages among REM and NREM. And it works very well on cataplexy, and that may be a reason why it works on cataplexy. And the more exciting perspective is certainly the orexin 2 agonist. We did report that last year in mice that with TAC925 in IV in humans, but here is in mice, there is a stop of sleep, so decreasing NREM and REM sleep. And just recently reported in New England Journal of Medicine a few weeks ago that it works very well. The oral drugs, the TAC994, increasing the MWT close to normal subject, increasing the weekly cataplexy rate. But there is some liver issue, so we move on to TAC861. So this is highly promising to decrease REM and REM sleep and REM sleep symptoms as well. So to conclude, the question asked could be, is narcolepsy a REM sleep disorder? Answer is yes. is the big discovery for narcolepsy, is in the definition of NT1. It's not enough because narcolepsy, the REM sleep disorder cannot explain sleep latency in REM, cannot explain PLMS, obesity, precursors, puberty. There's a lot of narcolepsy so far, type 1, type 2 comorbidity, and we need to better understand orexin deficiency, intermediate, normal, chronic versus transient, and how to better understand narcolepsy with normal orexin level and the different clinical curses of narcolepsy and the perspective for medication with orexin receptor 2 agonist. Thanks, and a little bit too long, sorry.